We really appreciate all those who made it this early in the morning, and I'd like to have Nishant Kumar come up here, a superb medical student who's just matched in Ann Arbor, and he's going to talk to us about rare disease on the plastic surgery in-service examination.
Thanks, Dr. Rosen. Thank you guys for having me here today. I'm really excited to be speaking about our research on the in-service exam. So the in-service exam, as many of you are aware, is administered every year by the AAPS. It is taken by over 600 residents across the country, but more than 75% of test takers are practicing plastic surgeons. And so the in-service exam committee seeks to balance the goals of both graduate and continuing medical education in writing the exam. As educators, it is important that we periodically review the content on the exam, and one such aspect that hasn't been looked at before is the frequency of questions in the exam that test rare diseases. Working with members of the in-service exam committee, we hypothesized that if the goal of the in-service exam is to broadly test the curriculum in plastic surgery, then questions testing rare diseases should appear with a relatively low frequency on the exam because they are indeed rare diseases. And so with that in mind, we reviewed in-service exams over the past 7 years from 2010 through 2016. We used the NIH Genetic and Rare Disease Database to define a rare disease, the GARD database. They define a rare disease as one that has a prevalence of fewer than 200,000 people in the United States, or less than 0.06% of the current US population. Here's a sample of our methodology. So this is a question from an in-service exam. I'm sure many of you know by now what the answer is, but it requires the test taker to know that this is van der Waals syndrome. But on top of that, it also requires the test taker to identify what the specific genetic mutation is in van der Waals syndrome, which again, as all of you know, is IRF6. We would then review these diseases by checking to see if it indeed was accounted for in the GARD database. And so we would look it up, van der Waals syndrome pops up, and that's how we would account for a question testing a rare disease. So we reviewed a total of 1,450 questions, and we found that 228, or approximately 1 in 6 question tests a rare disease. That works out to about 16%, and that was a pretty consistent trend across the 7 years that we looked at. We identified 159 unique rare diseases. The most common ones are highlighted here: compartment syndrome, Treacher-Collins, and Perry-Romberg disease. When we look at sections on the exam across the 7 years, the CMF section, or the craniomaxillofacial section, consistently tested a high number of rare diseases, and that might be just inherent to the CMF section in testing a large number of congenital and rare disorders. The breast and cosmetic section had the fewest number of rare disease questions across the 7 years. The core section is a relatively new section on the in-service exam. It was started in 2016, so it'll be interesting to see how that plays out in the coming years. And just to highlight the point on further analysis, the CMF section had twice the odds of testing a rare disease compared to the rest of the exam, while the breast and cosmetic section, less than half the odds of testing a rare disease compared to the rest of the exam. So where does that take us? So about 1 in 6 questions tests a rare disease on the in-service exam. That estimate might actually be a slight underestimate of the true incidence of rare disease questions in the exam because the GARD database that we were using is not all-inclusive. What do I mean by that? Diseases such as just isolated cleft lip or cleft palate that we would consider as rare diseases were not explicitly coded for in the GARD database, and so wouldn't be accounted in our analysis. And so again, the 1 in 6 might be an underestimate of the true incidence of rare disease questions. The real-world incidence of many of the diseases that appear, the rare diseases that appear on the in-service exam, is significantly lower than the minimum threshold set forth by the GARD database. So I've been told that Garland Syndrome appeared on this year's in-service exam. Garland Syndrome has an incidence anywhere from 1 in 50 to 1 in 250,000 individuals. I'm sure many of you recognize the manifestation up here on the stage, or up here on the screen, of Proteus Syndrome. I am curious to see how many of you here have actually seen a case of Proteus Syndrome. Perfect, and I hope it was case written, because I believe there's only 100 few documented cases ever. And I do want to reiterate, we're not saying that we shouldn't test rare diseases at all, just that we should be more mindful and thoughtful of how often we test rare diseases on the in-service and how we go about testing them. And I think to answer that question, we need to take into consideration what the purpose of the in-service is. I mentioned on my first slide that the goal of the in-service is a balance of continuing and graduate medical education. For many residents, the exam is often used as a tool of assessment to judge residents' competency and medical knowledge. But I guess the question is testing such a high frequency of rare diseases a fair way to distinguish between a good resident versus a great resident? Interestingly, for practicing plastic surgeons who take the in-service, they only require a pass rate of 30% to receive CME credit for the exam. Theoretically, that means they could take the entire exam without answering a single rare disease question. What does that mean for the future of the test? So I think it's important to consider the test writing process. It is a very arduous process, and there are requirements in how questions are written on the in-service. One of the criteria set forth by the committee is that every question have one explicitly right answer and every other answer being explicitly wrong, and that might lend itself to testing rare disease mutations, rare disease manifestations. But even so, we should consider removing the duplicates of these rare diseases in the exam. I was again coming back to Garland Syndrome. I was told it appeared at least twice in this past year's exam, which means a practicing surgeon or test taker who wasn't familiar with the rare disease would be docked several times for that. Where could we go instead? So one thing to consider is testing rare diseases that are surgical emergencies. Diseases such as compartment syndrome or necrotizing fasciitis require urgent clinical management skills, and that might be of more practical utility to a resident or practicing surgeon than knowing the specific genetic mutation of brachioautorenal syndrome. In our analysis, of the top 30 most frequently occurring rare diseases, only 2 were surgical emergencies, and that was neck fash and compartment syndrome. And finally, the ACGME milestones that have been set forth with several boards in plastic surgery and the graduate medical education departments have pointed out other topics of importance for plastic surgery, such as patient safety, professionalism, ethics, pain management, and those could be future areas for testing. I'd like to thank you all for your attention. Thank you, everyone here. I'd like to acknowledge my mentors for this project, Dr. Jolie, Dr. Biddick, and Dr. Livche, who's here in the audience as well, and happy to take any questions.
Yeah, sure. Is Dr. Garfien here? Thank you.
Good morning. Nishant, very well presented. That was a thoughtful paper, and I congratulate you on your work. In the spirit of one of my teachers, Dr. May, who enjoyed the rare disease, I think, as much as anyone, I have 2 questions and 2 comments. My questions are, what, in your opinion, do you think is the natural number of rare diseases that should be tested? I would imagine it's somewhere up from 0.06% of the test, which is the percentage in the population. So more of a prescriptive answer to your presentation. And my second question is, do you think the test should be organized in terms of what is taught in the plastic surgery curriculum or in terms of what the typical plastic surgeon sees or is likely to see on a given day? My comments are that it seems to me that we in medical education have over the past several decades, been in the business of directing both ourselves and our students to learn more and more about less and less. And I worry that there's real danger in this approach in that we'll only test, and forgive me for being cynical, but we'll then only learn what we tend to see on a regular basis. And I think that's a slippery slope. I think the directed tracks at a medical school, not just in plastic surgery, but across the surgical spectrum, is indicative of this, and in my opinion, not a great idea. By arguing, as you do in your paper, that perhaps too much testing emphasis is placed on knowledge that is not reflective of a typical day in a typical plastic surgery practice, I wonder whether you're setting the bar lower for future generations of students and practicing plastic surgeons. My second comment has to do with our responsibilities as physicians. You know, as you pointed out in your paper, the subject matter in plastic surgery is quite broad, and it's a challenge with hand surgery and craniofacial and cosmetic and reconstructive. But I would argue that, as you exemplify, our students are pretty smart, right? They're sort of the best and the brightest coming out of medical school, and I would argue that we should encourage them to learn as much as possible about as much as possible, not just what they're likely to see on a given day. And so, you know, lastly, if you're any of those patients that you showed in your presentation, for those patients, those diseases are not rare. They're very common. You might even say they're ubiquitous and omnipresent. And so not just for a surgical emergency or not just you know, for something that we can outsource to the internet or a medical encyclopedia or an app, we as plastic surgeons, I think, have the responsibility to recognize these processes as they occur. So again, I'd like to congratulate you. I wish you the best of luck at Michigan.
Thanks, Dr. Garfein. So just to repeat, your first question was, what would be the right number of rare diseases, or approximately the right number of rare diseases to test in the exam? In some ways, I guess that's getting to the point of where do we draw the line of how frequently we test these diseases on the exam, and I fully acknowledge that that's a very challenging and hard question to decide. I think the purpose of this study was to just define or point out where the line is right now. We use the GUARD database as kind of a global database of these rare diseases. But I think taking into consideration how frequently certain plastic surgeons encounter these rare diseases might help us better define where we should draw the line on the test. Dr. Lifshitz might be able to shed some more light on how the in-service exam committee decides how much or how many of these diseases to test. In terms of how the test should be organized, I fully acknowledge what you just said. I mean, I don't think we should stop testing rare diseases. That by no means plastic surgeons encounter these rare diseases at a much higher frequency. But again, I think being mindful of the purpose of the in-service exam, coming back to that, whether we need separate sections in the exam for residents and practicing surgeons, whether we need more specialized components of the exam for fellowship-trained plastic surgeons versus general community plastic surgeons.
Sean, thanks so much for a fantastic talk. Just for the sake of time, we are going to continue with the second talk. And I'd like to have Dr. Goldstein here. And he's going to speak about an analysis of 83 craniofacial center websites, creating craniosynostosis, being given inaccurate, vague, and inconsistent information.
Thank you. Well, Nishant, I guess I'm talking about a rare syndrome. The internet is increasingly being used for health information access by patients. A recent study in 2015 from Hospital for Sick Children showed that 98% of pediatric surgical families surfed for medical information. There are certain advantages to the internet, including that online inquiries can complement a face-to-face meeting. And those face-to-face consults with physicians can be highly time-constrained. The internet also provides further information for additional or forgotten family inquiries, and it's an opportunity to explore more types of sensitive inquiries. But there are disadvantages. Online information is difficult to regulate, leading to challenges in quality. Families vary in what they understand and their literacy of this information. Families can trust and act on misleading and inaccurate information. Often these families feel vulnerable and they're willing to accept any inaccurate information that provides hope. And lastly, with the use of search engine optimization, people who search the web end up at self-promoting and often biased websites. The aim of this paper is to review the content of search engine optimized websites of United States craniofacial centers and to look at them for incompleteness, inadequacies, inaccuracies, and variabilities, and also to document center-based misrepresentations. The methods were fairly simple. We used 3 search terms: craniosynostosis, craniofacial center, and craniosynostosis center. The first 30 websites that came up for each term were then collected, leading to 53 total after accounting for duplications. We developed a standardized list of questions and then recorded the answers from each of these websites. We also documented misrepresentations and inaccuracies. I want to share with you some of the results from some of the questions we posed. 1. Is surgery required for craniosynostosis? 11 centers don't mention that. 12 say sometimes it's required. 26 centers say mostly it's required. And 4 centers, or 8%, said that surgery is always required for craniosynostosis. From these 4 centers are the following 4 quotes. 1. Surgery is required for metopic, lambdoidal, and coronal craniosynostosis. The second center, problems with neural development can occur, such as learning disabilities or mental retardation. Because we can't predict which children will have these problems, treatment of craniosynostosis is recommended to prevent the possible increased intracranial pressure. More directly are sites 3 and 4. Site 3, left untreated, most forms of craniosynostosis can have profound effects, including death. Site 4, if left untreated, craniosynostosis will result in increased intracranial pressure and severe permanent head deformity, developmental delay, and possibly even seizures. Question 2, does the team have a plastic surgeon or a neurosurgeon or both? Turns out that both is the predominant answer, but 2 centers only had neurosurgeons. If craniosynostosis is untreated, does developmental delay occur? It's not addressed in 24 centers. 27 centers say that sometimes it will. 1 center says developmental delay mostly occurs, and 1 says it always occurs if craniosynostosis is untreated. Quote from the first site, left untreated, most forms of craniosynostosis can have profound results, including death. The second site quote you've seen a little earlier in my talk, if left untreated, craniosynostosis will result in increased intracranial pressure and severe permanent head deformity, developmental delay, and possibly even seizures. Question 4, are endoscopic and open techniques, cranial vault reconstruction, both mentioned? Well, 6 of the craniofacial center websites only talked about the open technique without a mention of endoscopic. All minimally invasive sites where it was discussed also did mention open techniques. Question 8, what is the maximum patient age for a minimally invasive approach? This is a really important question because as families are deciding their options, they need to know if the minimally invasive technique is available to them. Well, the maximum age is less than 3 months, 3 months or less in 9 centers, 3 to 6 months in 8 centers, and 1 center will go all the way up to 8 months of age. Quite a variable range for a family that needs to make a short-term decision. Is a blood transfusion required? 38 centers don't address that. 12 centers say that sometimes or all the times they require blood transfusion. 2 centers said only when they do an open vault reconstruction, but not when they do minimally invasive surgery. And 1 who does exclusively open says they haven't transfused recently. Well, one of those minimally invasive sites is extremely large volume. It's only endoscopic. It's well known, maybe one of the leading centers in the country. And their website says they have no transfusions. But a recently published paper about 3 years ago said that they had a 7% transfusion rate for sagittals. Interestingly, I grabbed this data about a year ago, and I re-looked at the website 2 days ago, and the no transfusion claim has now been removed. Question 8. How many days do you need to stay in the hospital afterwards? Nearly universally, the endoscopic is 1 day, but the open approach is 3 to 5 days. For some centers, some just say it's 2 days, and others say it's up to 5 to 7 days. I want to lastly focus on what I call misrepresentations. They're both clinical in nature and center-based. And we've discussed examples of the clinical ones, like all craniosynostoses require surgery, there aren't significant complications, if untreated they'll lead to delay, and they don't require transfusions. What I want to focus on is the center-based misrepresentation and just share a couple examples with you. Example 1, the craniofacial clinic at X is the only clinic in the region that includes a multidisciplinary team. Well, you go down the road about 13 miles, and this center has this on their website. The craniofacial center team at Y offers coordinated interdisciplinary care for a wide range of craniofacial anomalies. Either the region is only 12 miles, or it's a little bigger than that, and they've kind of misinterpreted things. In fact, that same website from the hospital goes on to define that region. It says we're the premier provider of healthcare for children, infants through adolescents in our region: Nebraska, Iowa, South Dakota, Wyoming, Kansas, and Missouri. And I didn't highlight Nebraska. That's a direct quote from their website. Secondly, it says that our craniofacial specialists use some of the latest techniques and technologies not available anywhere else in the region. Well, interestingly, neither website X nor website Y are Cleft Palate approved, ACPA approved craniofacial teams. A second example is that the Cleft Palate and Craniofacial Institute at Z, established in 1978, is the largest and oldest center of its kind in the Midwest. I think there may be a few other centers that were a little older that are listed below. This website goes on to say is that we're viewed as the national leaders in this type of surgery, endoscopic craniosynostosis repair. And that center is not the University of Texas San Antonio nor Boston Children's. In fact, that hospital, Hospital Z, has a Google search ad which is entitled Craniosynostosis Facts. So the websites are inadequate and incomplete. They're variable and inconsistent. They're inaccurate. They can misrepresent things. But as a caveat, most of the websites are good and without significant difficulties. But I did want to have the opportunity to share this with you all, and thank you very much for your time.
The discussant is Dr. Timothy King.
Hi, Tim King from UAB, No Disclosures. This is a very interesting paper, and I appreciate the work you've done to look at these different websites. I have a couple of thoughts and a couple of questions. First, I think it's really important, as you said in your talk and as we saw in the social media session yesterday, that patients are constantly looking at social media and websites. You said, I think, up to 98% of families are looking at websites. And so I think it's imperative that we as professionals have very accurate and complete and not misleading information on our websites. So a question to that is, do you know if there's any data on patients' interpretation of these websites? If they go to a website and find something that's inaccurate based on another website, how do they interpret that? And does that influence their decision on where to go for treatment? The other comment I have is I really think it's important for us to police ourselves, and if we are going to, otherwise someone else will police us. And so the question then becomes, how do we manage these websites that have incorrect or misleading information on them? Does ACPA require website review for craniofacial programs to be certified? Just like when we go for our board exams, we're required to submit our websites and advertising to the board, should that be required for MOC recertification to verify that we are giving accurate information to our patients? Do you have any other suggestions or thoughts on what can be done so that we as a group can make sure that we're giving valid and correct information to our patients and aren't misleading the public on what we're doing?
Thanks for your questions, Tim. And please stand up if I don't address all your questions. In regards to the data on family perspective, well, first of all, families, 80% of the time, will go to a public website before they go to one of our hospital or university-based websites, and that's a problem. Having said that, about 75 to 76% of them view our hospital websites, and our means the medical profession, not craniofacial, our websites as trustworthy and reliable, and they only trust about 26 to 30% of the public websites. Nevertheless, that's where they go first. And frequently, there's another set of data that shows that most patients the number is 3 websites that they go to. They go to 1, there's conflicting information when they go to 2, and they kind of then go to a 3rd. The second part of that, though, is that only about 50% of them share with their physicians or ask their physician, their pediatrician, or us information they get on the web. So it may be inaccurate, and they may not even share it with us. The second question is, how do we manage this as a society? There's a couple ways to go at that, and perhaps the easier way is at the physician-to-patient level, and that is we need to recognize that they're on the internet. They absolutely have been there, even if they don't say. We need to ask them. And then we need to, I think, explain the problem to them, guide them to appropriate websites, and encourage discussions after your consult with themselves, or they can call their pediatricians, and we need to encourage our pediatricians or other referring doctors to be doing the same. From a society standpoint, I think we've learned you can't really control quality on the internet. That was a big topic yesterday that was discussed in a really nice social media website. Does the ACPA or the ASCFS have a policing role in this? Perhaps they do, and it needs to be brought up either under quality or ethics committees. But lastly, I kept mentioning that some of these questions aren't addressed in our websites. And what I meant by that is that many of our websites that are on these search engine optimized, your hospital's optimized you, and you go to our websites, and our websites are one page. It says what we treat, a list of conditions, who's part of our team, and who you can call to schedule an appointment with. So families who are going to come see you in Alabama may go to a website, and your website says nothing to help them, and then they're off onto public websites. In addition, we have to be careful on our websites. A lot of our websites, and I'll say 30 to 40% of them, link patients into public websites, and it's a one-way link. And so you go to Cranio Kids, or you go to CAPS, or you go wherever, and you end up not being able to get back. And many of the like CAPS websites for craniofacial clinics and centers, you have to pay to be on those. I know a broad answer, but I hope that answered your question.
So if there's an error on the website and you're the plastic surgeon for the craniofacial team, when you are being evaluated for your MOC, could you be held responsible for that?
Yes, if you have to go through MOC, or if you think the plastic surgeon is the leader of the craniofacial center. Many of the centers, the leaders, the medical geneticist or the or the speech pathologist, and you may not have as much direct control over that website.
Great. Dr. Goldstein, thank you very much.
Sure.
It was an excellent talk.
Thank you.
Next speaker is going to be Thanispoon Bunispat, and we're going to be talking about letting go under control. Resident is the primary surgeon for non-selective series of Furlough Palatal Plasties. Sorry, it's a bit dark here.
All right, good morning. Thank you so much for your attention today. We have no disclosure. As a background, as an apprentice, most surgeons yearn for a steep curve of graded technical responsibility, but as mentor, many are hesitant to bestow the same latitude onto their trainees. And the hesitancy of the mentor is mostly born out of a sense of responsibility to patients' well-being, along with other pragmatic concerns. And a variety of factors influence the decision of an academic surgeon to so empower a trainee. And these include the expected technical difficulty of a given case, the resident cognitive preparation and prior evidence of proficiency, and the practical demands to optimize work productivity. So with those ideas in mind, let's talk about the elegant Furlough palatoplasty. And despite the sound anatomical rationale and evidence of clinical effectiveness, widespread adoption of the Furlough technique has been uneven. Almost all published theories have employed the Furlough selectively, mostly for non-syndromic and/or narrower clefts. And some surgeons consider the Furlough procedure technically challenging, or difficult to teach. The American Board of Plastic Surgeons Maintenance Certification Tracer benchmarking data indicate that only 14% of the soft palate repairs were performed using the Furlough approach in 2016. Therefore, many finished their plastic surgery training with limited experience performing, assisting, or even observing the double opposing C-Plasti velar repair. And our study objective is to measure the outcome of a consecutive, non-selective series of primary furlough palatoplasty in which the plastic surgical residents perform all steps of all procedures under the immediate supervision and guidance of the senior surgeons. And as a disclaimer, we acknowledge that a protocol in which the residents are assigned as primary surgeon may be controversial. The decision how and when to confer procedural responsibility to a trainee ultimately is a highly personal decision. Thus, the importance of providing conscientious preparation and supervision and carefully documenting clinical outcomes to justify this pedagogical approach. So our method, we have a retrospective review of 75 consecutive primary palatoplasty over a 6-year span, and the plastic surgical resident performed the velar repair using the Furlough technique for all patients. And all clinically relevant outcomes were measured. Speech outcomes were considered only for patients aged greater than 54 months or 4.5 years. That's a single surgeon and a single speech pathologist. For the resident preparation, one point that we want to emphasize is the critical importance of the resident education. And in order to help prepare the resident, a detailed 12-page Furlough flight plan was provided in advance and carefully reviewed. And here's an example of our Furlough flight plan. And this document is written by the senior surgeons and covers everything from pre-op assessment, handling of the ET tube, instrumentation, positioning, the eyes, and through to markings, injections, 45 points on dissection, flap inset, and post-op orders, for example. For our outcomes measure, the independent variables include the veil cleft type, the patient age, recent year of training, presence of dermatal delay, presence of syndrome, and history of adoption. The dependent variables measured include the nasal resonance rating from 0 to 6, articulation error, presence of nasal air emission, nasal frication, grimace, snort, and presence of fistula, requirement for secondary VPI-related surgery, and the duration of the procedures. Our results. Here we show a table of the patient age at cleft palate repair. And you can see for all patients, the mean age is 17.9 months. But when we exclude the syndromic, adopted, and submucous cleft, the mean age dropped down to 10.6. And here's just a distribution of the age with the median age of 11 months as shown here. And this is the distribution of cleft type by veil type. The submucous cleft here is classified as type 5. And over 2/3 of veil type 2 or 3 is shown here. And this is a table of the palatoplasty technique by the cleft type. And while the Furlough technique was used for all cases, in 35 instances, additional hard palatal incisions and dissection were required, specifically for the hard palate repair. Usually the 2-flap technique is shown here. And this is the pie chart, the syndromic and the PRBN sequence. And 27% of the cohort has either a defined syndrome or the PRS. And 17 of the patients were diagnosed with dermatal delay, and all of those patients are in the syndromic or the PRS patients. For the speech outcomes, the nasal resonance score is shown here, and over 56% of the patients have no nasal resonance score, or they were normal. And over 95% of the patients have non to mild and mild score. The articulation error is 14.6%, nasal air emission of 2.4%, and the fistula rate of 5.3%. And all fistulae were located in the mid-hard palate. Secondary surgery for fistula or VPI, the reoperation rate for fistula was 4%, and the reoperation rate for VPI-related symptoms was also 4%. The patients are different. And the impact of the mental status and the phenotype on nasal resonance. The y-axis, you can see the mean resonance score. And patients with syndromes or developmental delay were not unexpectedly found to have a higher likelihood for hypernasal resonance. And patients with submucous cleft tend in the same direction, but the number was not statistically significant because the N was too small. The resident year of training and the procedure duration. And by the third year, the residents were faster at performing the procedure. We were unable to detect any association between year of training and surgical outcomes. And so in conclusion, the plastic surgical residents are able to achieve superior clinical results performing the entire procedure under close supervision and guidance of an assisting surgical mentor. Without screening patients, without the use of supplemental maneuvers, speech and facial outcomes were attained that were comparable to published best practice. This finding supports the use of the Furlough repair for all patients and all cleft type, and the deliberate process of mentor supervision and support, as described, may hasten the surgeon's journey from trainee to master. Thank you for your attention. That's the contact.
Dr. Albert Wu is the discussant.
Thank you very much for your presentation on discussing the series of furlough palatoplasties that were performed by residents at your institution. I think it really highlights the possibility of each of us as attending physicians to give our residents greater autonomy in complex surgical cases, regardless of the subspecialty that we're involved in. I particularly appreciated the idea of a flight plan, and it's something that I think as physicians and teachers we can try to take into account in our own teaching endeavors. I also appreciated the fact that you broke up the palate into two different segments where you're talking about the furlough palatoplasty predominantly for soft palate reconstruction, and then also breaking it up into the hard palate reconstruction with the two-flap or von Langenbeck repair. The one element that surprised me was really kind of the suggestion that all plastic surgery residents should be trained in furlough palatoplasty techniques, and the possibility that some of our residents may not be trained in some of these techniques due to technical challenges or difficulties in teaching. And so my question to you would be whether you would suggest that other training programs who do not perform double opposing Z-plasties are indeed actually doing a disservice to their residents. And actually, as a corollary to this, the other question arises whether teaching furlough palatoplasty alone is actually adequate for resident teaching. Namely, one of the questions that arises is, for those institutions that are teaching furlough palatoplasty, should we also be teaching other techniques, including the radical intravelar veloplasty advocated by Dr. Summerlad in cutting? So once again, this is a fantastic presentation. I really enjoyed it. Congratulations to you, and appreciate it.
Thank you for your questions. So your first question is about whether we are doing the disservice by not teaching the furlough palatoplasty. I think it's good for our residents to get a broad training and to get exposure to all types of repair and all types of procedures. And as we shown, only 16% of the soft palate repair was performed using the furlough approach. So I think there's some room for maybe some improvement in the resident exposure to getting exposure to this technique, for example. And to address your second question, whether we should also teach them other techniques. And I think there's been a lot of discussions about the best way for the palate repair. And I think as a trainee, as a resident, I think it's best to get exposure to everything. And some attending might have preference for the furlough approach, while others might have a preference for the Summerlad approach, for example. And I think it's somewhat hard to direct like what exposure the resident should get because the attending have their own preference. So.
Dr. Weber?
Hi, Bob Weber from Baylor Scott and White. 2 questions for you. You mentioned that the residents were supervised the entire time. Can you tell us a little bit more about that supervision? In other words, was the senior staff in the operating room but not scrubbed in? Were they scrubbed in but not really assisting? Or were they actively assisting? Because that type of supervision makes a difference in the education. And then related to that, was the attending basically verbally directing the resident, okay, do this next, or were they more silent partners? So clarifying that aspect of the education would be helpful. And then secondly, what role does video play in the educational process? You know, having a 12-page flight plan, that's a great idea, but in my mind, the first thing that came to mind is I'd want my residents to watch a narrated video of how to do it. And then also, what role would video play in the operating room? But thank you, it's a nice paper.
Thank you so much for your question. So the first question, the primary surgeon is assisting and scrubbed in. And my PI can shed more light on that if you want. And in terms of your second questions, that's a good suggestion. I don't think we did that. I don't think we had a video in the past, but that's a good suggestion to have. And my PI might have something to add.
I'm going to break in with a question from Twitter. Can you be a little bit more detailed about what went into the decision as to when the resident was ready to take this whole operation on?
I can answer that. So as the senior surgeon, I retracted and I did suction. And I talked throughout the entire procedure. I'm not sure where that person just went who asked a good question. And no music on in the operating room, so they can stay focused, and I talked them through the entire procedure. And they were ready the first time they came into the operating room. So I let every resident do the procedure. I assist every resident, whether they're a first year or a third year. That video was a great idea.
Thank you.
Okay.
Next, I'd like to have Martin Carney here to talk about 5,000 free flaps and counting, 10 years of single academic institution's microsurgical experience, and a practical guide to developing a successful surgical culture. Thank you.
Thank you. Thank you to the association for the invitation to speak this morning. It's an honor to present at such a prestigious meeting. As the title, no relevant disclosures. As the title indicates, the purpose of the study includes categorizing the pen microsurgery experience to date, as well as predictors for flap salvage, and to provide an institutional narrative for the development of a productive surgical culture. In 2005, alongside a change in leadership, pen plastic surgery largely operated out of a single location. Today, Penn has expanded to 8 campuses, further impacting the geographic distribution of reconstructive microsurgery throughout the Delaware Valley. In 2005, there were 5 faculty whom all remain, but this has evolved to include 19 full-time faculty. None of these recruited faculty have left, demonstrating continued commitment to the Penn plastic surgery mission. Diverse faculty recruitment and retention remains a key aspect to successful program development. The entire story cannot be told without looking at education. The number of trainees from 2005 to 2015 has tripled from 8 to 25. Similarly, the number of microsurgery fellows increased from 1 to now 4 per year. This focus on growing a successful surgical culture has led to a drastic increase in free flap volume, with less than 50 per year in 2004, 200 in 2006, and over 700 free flaps in 2016, accounting for over a 3-fold increase during the 10 years from 2006 to 2016. Here's the flap volume broken down by year and shown as a depiction over time. with the 5,000th free flap within the study period occurring in December of the previous fiscal year. Along with the resident's well-rounded education, here we have a graphical depiction of the average free flap volume of a chief resident upon graduation. The upward trend remains similar to other aspects of the program, and around 2012 actually shows some artificial deflation. The blue lines indicate 2 graduating chief residents, while starting in 2012 and continuing with the red lines, the chiefs increased to 3 per year. Concurrent to clinical volume increase, publications in peer-reviewed journals have also increased over the last 15 years. The two go hand in hand with data consistently helping to shape clinical decision-making, with the majority of these being resident-derived publications. Roughly 40% of these publications pertain to reconstructive microsurgery, and as an example of how clinical volume has led to an evolution in practice, Dr. Wu examined factors predicting flap salvage. This 6-year review of microvascular compromise by Mirzabehi et al. Looked at 2,300 free flaps with notable salvage predictors, including time to take back, thrombophilia, and thrombocytosis, surgeon experience, and mechanical thrombectomy. These findings were addressed in an institutional protocol change, namely not exceeding 2 hours for flap checks and postoperative days 2 through 4, patient counseling and aspirin usage for thrombophilia, as well as patients remaining on a plastics and reconstructive dedicated floor. With evidence-driven implementation, there was a shift to earlier salvage attempts on secondary analysis in the more favorable golden period within the first 48 hours postoperatively. Re-examining our previously published experience, we performed a 10-year retrospective review of all free flaps performed at Penn, including breast, head and neck, and lower extremity. The cohort for the 6 highest volume microsurgeons was used. Inclusion criteria for takebacks was based off of the system previously published by Mirzabehi et al. For acute microvascular compromise. Takebacks for SSI, hematoma, and planned debridement were excluded, and this protocol is also IRB approved. Statistical methodology included both univariate as well as multivariate logistic regression between salvage and failure groups. So we looked at 97% of 5,000 consecutive free flaps. 70 patients met the flap takeback criteria for acute vascular compromise, which resulted in a takeback rate of 1.53%. Of those taken back, 65.7% were successfully salvaged. Here we have the patient demographics with those flaps that were able to be salvaged and those that resulted in flap failure. Thrombophilia, either laboratory or confirmed or history of, provided the only significant difference on univariate analysis. When looking at perioperative factors, differences were seen in intraoperative thrombosis, usage of thrombolytics such as TPA and urokinase, as well as postoperative revision of the anastomosis on takeback. Most flap compromise occurred in the first 48 hours, with salvage being less likely as time progressed. On multivariate prediction of salvage, improved outcomes were noted with non-existence of thrombophilia, no thrombosis at the index procedure, take-back revision of the anastomosis, as well as chemical thrombectomy. Looking closer at this institutional experience, we see the same increase in total flap volume in green with take-back rates in red, remaining fairly linear over this time period. Just as a note, the 2005 outlier skews the line slightly downward where it should be just a slight increase. When looking at breast flaps alone, which comprise of 75% of the institutional free flap volume, the trend remains the same with a consistently low take-back rate. And further stratifying by surgeon with flap volume divided into breast and blue versus non-breast and green, take-back rates remain consistent across the group. These are shown in red. Despite surgeon experience, the take-back rate remains consistent across the surgeon cohort. In conclusion, when looking at 5,000 free flaps over a 10-year period, we demonstrated an overall microvascular compromise take-back rate of 1.53% and a salvage rate of 65.7%. The clinical growth has allowed for simultaneous research output, providing evidence-based change within practice. And finally, production is dependent on institutional, faculty, and staff support. Thank you.
Dr. Jay Agarwal will discuss.
Martin, thank you for a very nice presentation. The University of Pennsylvania has clearly seen explosive growth over the past 10 years in terms of the number of faculty, trainees, the number of free flaps performed, and the number of publications, the academic productivity. So you should be commended, and your team under Dr. Cerletti should be commended for that work. Your work that you present today is not only very important, but very timely. As you may know, CMS is engaging medical specialties to identify quality measures that are unique to their specialties, which may ultimately be linked to reimbursement. And one such quality measure that's being considered is return to the operating room. You guys described a large series of free flaps with a return to OR rate of about 1.5%. Recent literature has also suggested that complications with free flap surgery may have some association with operative time. So my first question to you is, over this 10-year period that you've investigated, did you observe any trends or changes in operative time and any association with complications such as return to OR with operative time? My second question is related to flap type and site of reconstruction. Recent literature suggests that there may be some association with complications depending on the type of flap or the site of reconstruction. For example, muscle flaps may have a slightly higher flap loss or complication return to OR rate than fasciocutaneous flaps, and head and neck flaps may have a higher complication rate than lower extremity than breast reconstruction. And finally, my final question is related to your database. I mean, clearly the University of Pennsylvania has a very robust data collection process. My question really is, who controls this database? Is it a plastic surgery database? Is it an institutional database? And the reason I ask is because our group has recently published an article in PRS which highlights the inaccuracies in free flap specific data in the NSQIP database after 2010. And as a result of that, NSQIP has placed a disclaimer on their data suggesting that the free flap specific data after 2010 is inaccurate. So how do you at your institution ensure quality and accuracy of that data? Thank you.
Thank you, Dr. Agarwal, for those excellent questions. So I'll just go back through in a stepwise approach. So firstly, the trends in the OR time. So that was actually something that we did not plug into the regression model, but certainly prior to publication, something that we should look at and address, absolutely. And second question for flap type and site. So just looking at the flaps that were taken back out of the 70, 50 were breasts, 13 were head and neck, and 8 were lower extremity. And denoting that our institution has a higher breast microsurgery volume. So that's when you compare that to the totals. So you have 1.4% for the breast and 1.7% for the head and neck and lower extremity. So there's a slight difference, although we haven't plugged that in to either univariate or multivariate analysis to see if there's any statistical difference. And then your third question on the database. So what ours compared to something claims-based, such as the NSQIP. So the research fellows, such as myself and Dr. Weissler, are sort of instructed to and encouraged to collect operative logs from the different microsurgeons at the institution and categorize these each year. And I'm fairly certain this has been going on for around 8 years at the start of the research fellowship. And in terms of comparing that to claims-based data, I think there's a lot of literature out there now that shows limitations in NSQIP the data sets, years included. And I think that really having the granularity of an institutional data set such as this one and others is very important. And also, just as an aside, we have a lower extremity free flap database, which is shared with Duke. We also have an abdominal wall reconstruction database within our division as well. So thank you.
There are two questions from Twitter, which actually have to do sort of with your residency expansion like that. One is, how did you secure funding to increase your residency to that degree? And then the second question is somewhat related, is how do you, let's see what that, let me go back to it here. The second question is, how do you, with that many microsurgical cases, you said that there's a good balance in the residency. How is that possible?
Okay. I think Dr. Saletti might have a better answer for the funding and the education.
You know, we now are going to go into 4 chief residents, 4 microfellows. So, you know, it's with the insidious growth of the program, we have added residents. But if you look at the graduating residents PSOLs, they're in about the 90th percentile for everything. So it's a very balanced surgical experience. The funding I addressed yesterday. Penn took over a residency program, or a hospital that had some open spots, and we grabbed one of them and that's how we started the independent program at Penn. And then, as I said yesterday, you know, the hospital does reasonably well on these cases, and they're spread out over multiple Penn institutions. So we have argued, you know, in order to keep up this productivity, they have to come up with funding beyond the cap, and that's what they've done. They fund the microfellows, and they funded an additional resident. So I think that answers. Thank you.
Okay, we have time for one question, and I appreciate everybody staying on time, including the discussants. And go ahead. Dr. Gassman.
Okay. Thank you, Dr. Sens. So I'm just thinking scientifically how you could break this down to figure out what is your secret sauce, if you will. And you have, I know, a very prominent otolaryngology group that does their own head and neck microsurgery. You've had a lot of prominent fellows that have gone on to other institutions. So you could ask the question whether this is a, you know, plastic surgery in Penn specific. Is it a Penn specific thing, or is it something that is other? By just comparing a couple thousand head and neck free flaps done by, I understand they're not plastic surgeons, but they're otolaryngologists who do a fair amount, and then look multi-institutionally at some of your graduates. And it's just something, it's more of a comment than a question, and just something to think about, because obviously you're doing something very well. It's not just your flap loss rate, it's your take-back rate is exceedingly low. Because there are other groups have similar flap success rates, but not your flap take-back rate success. And I think that's a big deal, especially with reimbursements and rehospitalizations and not being reimbursed and so on. So just something I guess I would challenge your group to think about, because you could actually break it down by having positive and negative controls in your study to figure out where is your success coming from.
Okay. All right. Thanks for the comment. We'll move on to the next session.